Do you see yourself as a patient advocate, come hell or high water, I'm going to do, that's what's necessary for my patient, and damn the torpedoes, full speed ahead?
Absolutely.
Even if it bankrupts their insurance companies?
And this may surprise you, but I also consider what we do as being a patient advocate.
I was going to ask you the same question.
Okay,
You answered it.
very good. I answered it ahead of
The
time.
answer is yes.
Okay, but aren't there ridiculously expensive therapies that might be useful, but are simply so many standard deviations out of the box that you couldn't possibly afford them? Would you recommend them if your patient could benefit from them?
If you have a single patient sitting in front of you in your office and that patient can benefit from a medication or a procedure, then you recommend that medication or procedure regardless of cost.
And these
it's
guys
not in
take
the
a look.
purview of the clinician, I think, to make that
But that's their call,
distinction.
right? And that's what you're ganging up on them about, it sounds like to me. No? What do you think?
Well, I think that's the hard piece of it, because if I was looking at the patient to the face, I want to offer them the same therapies. I want to provide the life-saving resource today if I had that in my power. That's not the hat I'm wearing working for the insurance company. I'm not. So we have to make sure that our resources are allocated properly, and unfortunately that does tend to be jumping over.
Actually, what we do is we've been very fortunate to get samples from the companies, and we will support patients with samples while they're waiting for their approval.
Okay, but that's not going to work long term. Right?
But
I mean,
it's
that's
still,
a stopgap.
what it does is it says there's a commitment to getting this done, and that we believe that one way it should be solved in their favor.
All right, let me put this out to the payers first. Because you do have a view of the landscape that the individual practitioner does not. The individual practitioner sees one patient at a time and sees an individual's risk. And you, although you have to pay individually, also see the bigger landscape because you know what your budget is. How do you determine whether these agents are being used appropriately?
Again, and I think the insurance industry being very highly regulated and subject to both internal and external appeals process, my view is that in general, we're very permissive in terms of coverage of expensive agents. We want to make sure that they're used in appropriate patients. We want to make sure that they're being used according to FDA or compendia citations. And that's our obligation. We had a system back in the 50s and 60s called indemnity insurance where there was no managed care. And whatever the doctor wrote, prescribed, wanted to do, they just sent in a claim and it got paid. Well, that was an unsustainable system, and that's why we are where we are today. So it is also our job, and that's why I said I also feel as an advocate for not only the clinical care that our members, our insured patients receive, but also their financial interests.
Okay, and what about you? Do you think that these agents are being used appropriately, and what do you mean by appropriately anyway?
Sure. So first of all, I think the next question will be, do patients have access? And I think by using them appropriately, it means the right patients do have access.
Okay, but who determines who's right? Is it you or him?
I think it's a partnership.
Okay, do you see them partnering with you, or do you see them being adversarial?
The latter.
The latter.
Yep.
But why are you agreeing so quickly? Are you adversarial?
Well, because I can understand, I can understand from both sides of the fence where there's challenges and where we're going to have to come to better agreement to offer new therapies to patients who really derive great benefit from them. But there's also the cost challenge that the payer has to constantly weigh and is accountable for. So I understand both viewpoints, and I understand where I'm a barrier to you providing great care for your patient. I can see where that can exist. And I think there has to be greater dialogue. And also, I think that the manufacturer has to come to the table to be cost competitive.
All right, the manufacturer, I'll be the manufacturer.
Okay.
I just spent 2 trillion gold grinkles developing this drug. Along the way, $1.5 billion gold grinkles were spent on blind alleys, right? If I'm going to be sustainable and provide new pharmaceuticals for the world, I got to charge what I'm charging. Otherwise, we stop. No?
Absolutely. I just want to say 2 things. One in response to what you just said,
What's
and the
a
other.
grinkle?
You never watched Rocky and Bullwinkle.
I'm sorry. Yes, I did.
is that I don't think this is a partnership decision. I think this is a physician-patient decision, what medicine to use.
But they got the money.
It doesn't matter. I think the decision is the physician-patient decision. Now, they can then come down on us and go, no, we're not going to do it, but we've made the decision. And I think that's really important. For some reason in this conversation, the pharmacy benefit managers have not come up. And they're
Here they are.
Okay, and here they are, and they're the intermediary. 4 companies grossing $400 billion a year or so in sort of hidden negotiations that without any transparency. So I don't even know, I don't think we know what the true cost of drugs is. The list price of a drug is definitely not the price that the PBMs pay.
All right, and
So
what
we
about
need to bring
this?
them into the conversation.
You guys, and by that I mean the payers, certainly look at the list price or the cost that you actually can get the drug for as one factor in prescribing this drug, and need is another, and do you meet criteria? But what about the long-term effects on America? That is to say, if you start approving these fairly expensive drugs, down the line, 10, 15, 20 years from now, the heart attack rate's going down, the cabbage rate's going down, the stent rate is going down, the stroke rate is going down. Your out-of-pocket's going to be way down compared to where you are now without these drugs. Do you factor that in?
Well, I mean, you're talking about HEOR data, health economics outcomes research.
Yes.
And maybe what you say is true, but maybe not. Again, that's where we get into the more technical analysis, number needed to treat, calculations like that.
By the way, if that's not true, if what I'm saying, what I proposed, does not pan out, then what are we doing anything for?
Well, and I can tell you that it's not true, because if it were true that providing all the medicines and the care that we provide is lowering costs, we would see premiums going down every year. But we see a huge increase in premiums every year. So we're paying more for medical services. We're getting some marginal improvements in event rates, but the cost is still going up.
Where is that cost? Is it technology? Is it medicine? It's certainly not personnel.
And let me ask you this. Is the cost for heart disease, or is it for everything else that comes as
Cancer.
these heart patients
Like
are
the
living
last
longer?
3 months of life.
Or is it?
I mean,
Or cancer.
it's always appeared to me that preventive care is very expensive because people live longer and use more health care.
Right.
Is that what's going on? Or are people simply dying of heart disease the same rate and these things have no impact?
No, but they're not, and we know that.
Yeah, we know that they have an impact.
Okay.
Clearly they have an impact.